Welcome to the Ghanaian obstetrician. Today we talk about uterine contractions and oxytocin use. So in normal labor, you have regular effective contractions causing progressive cervical dilatation that leads to the birth of the baby. Now, we're talking about uterine contractions in the context of fetal monitoring. And this is part of a whole fetal monitoring, continuous fetal monitoring interpretation series. So these uterine contractions compress spiral arterioles within the circulation and interrupt blood flow to the intervillous space, essentially limiting blood flow in an already hypoxic environment for the fetus. The fetal environment is naturally hypoxic, with the baby sitting at about 70% oxygen saturation, and this drops further to about 30% when labor starts. And this is caused by the contractions, but babies normally cope with this with no problems. Maternal pushing efforts during the second stage will also further decrease maternal oxygenation and therefore fetal oxygenation. Uterine contractions are generally assessed in various ways. We often use maternal perception, how much pain the mother is feeling, and how often it's coming and going to sort of give us an idea about how many contractions the mother is having. The commonest one we see on the labor suite is palpation of the abdomen. We could also use the monitor from the CTG machine, the TOCO monitor, to monitor contractions externally. So that's external monitoring. Or we could use an intrauterine pressure catheter to monitor. Generally, during monitoring, we'll assess various modalities of the contraction. We would look at 5 features of every contraction. We look at the duration, the frequency, the intensity, the resting tone, and relaxation. You'd realize that, like a vaginal examination, when you leave one portion out, you leave a lot of information out. So we realize that a lot of people are used to just doing dilatation for vaginal examination and not checking anything else. You lose a lot of information because you want to know if membranes are intact or not. You want to know station. You want to know position. You want to know couples. You want to know molding. You want to know whether there's any asyncretism. These all give you important information that you could use to assess progress. The same way when you're assessing a contraction, apart from just knowing the frequency, you want to know how long the contractions are lasting. You want to know if there's a resting tone in between. You want to know the intercontraction interval. You want to know the intensity of the contraction. These are all important features that we sometimes ignore. Now, let's think through why these are important. Now, incomplete recovery of fetal oxygen saturation to baseline levels occur when contractions are occurring every 2 minutes or more. So this means that we normally check contractions over 5 minutes. So if you're having over 10 minutes, excuse me. So if you're having contractions every 2 minutes, it means that you're having 5 in 10 contractions or more. Then for every phase of this contraction, you have incomplete recovery of fetal oxygenation, and therefore you'll be having accumulation of carbon dioxide and H+. You start with respiratory acidosis, which can progress to metabolic acidosis. We also know that contractions at intervals less than 2 minutes associated with decreased oxygenation. So again, it comes to the same point. And the ideal intercontraction interval should be about 2.3 minutes. So that means over a 10-minute period, ideally, you should have 2.3 minutes resting time between the contractions. So essentially, you probably need just 4 contractions. And researchers also showed that there's a decrease in fetal oxygen saturations over a 30-minute period when you have 5 or more contractions. So these are key things you need to have in mind when you're assessing contractions and how many contractions and resting tone and the intercontraction interval. And therefore, in current NICE guidelines, Contractions that are deemed adequate are 4, and anything from 5 or more is deemed hyperstimulation or excessive contractions. I know the new labor care guide from WHO still uses the old 5 contractions being the cutoff and more than 5 being hyperstimulation, but we need to keep in mind that based on the physiology and the research, 4 is the number, and if you have 5 or more, you're probably hyperstimulating. So the features of a contraction, look at the frequency. We count the number of contractions in the window of a minute, and then average it in the 5-minute window and in a 10-minute window, and average it over 30 minutes. Normally we want about 4 contractions. If you're having less than 2 contractions, you're having too few. Your duration of your contractions, so you want roughly about 40 to 60 seconds, lasting about 40 to 60 seconds. If you're having contractions that are lasting more than 90 seconds, so going to 2 minutes, it's lasting too long. And if it's lasting more than 2 minutes, you have a hypertonus, which could be detrimental to fetal oxygenation. You want the intensity to be moderate or strong. You want there to be resting tone in between contractions, because then the baby gets time to breathe, in the sense of the word. And then the intercontraction interval, you realize that the ideal time is about 2.3 minutes. So anything more than 90 seconds will be ideal for babies to recover. Now, sometimes we just count the number of contractions and we make a mistake. So let's give an example here. So hypoxia can ensue even if you're having 4 in 10 contractions. But if each one is lasting 90 seconds, so essentially over a 10-minute period, for 6 minutes, there was cumulative uterine activity. And this would be similar to having a 6 in 10 contractions, each lasting 60 seconds. So you realize that it's not just the number of contractions, it's how long the contractions are lasting. Therefore, you could say you have just 4 in 10 contractions, but essentially they are lasting too long and you need to tone down those contractions. The commonest risk factor associated with uterine heart rate abnormalities in the infant trial was oxytocin use and contractions. And like we've said, uterine activity at intervals of less than 2 minutes will reduce intravenous flow and fetal oxygenation. We know that maternal pushing also decreases maternal oxygenation, which also increases the risk of acidemia to the fetus. When you're having 5 or more contractions in 10-minute intervals in the second stage, the risk of neonatal acidemia is increased. We know that fetal cerebral oxygenation reaches its lowest level at 92 seconds after peak of contraction. We need at least about 90 seconds to return to baseline. So if CTG abnormalities are secondary to increased uterine activity, oxytocin infusion should be stopped or reduced. This is cardinal. And sometimes you need to even give a tocolytic agent if your hyperstimulation is not resolving. And a lot of medical legal issues have related to the misuse of oxytocin. We need to understand that oxytocin is a high risk drug, and we need to treat it as such. We therefore have to be very cautious when using oxytocin. Uterine myometrium, we know, becomes progressively more sensitive to circulating oxytocin. So let's do some deep learning to oxytocin. We know that safety in the use of oxytocin will improve with deep learning or understanding of what oxytocin is, the dangers with its use and how it works. The same way we've come to understand that understanding fetal heart rates comes with deep understanding of the fetal physiology. So we know that uterine response to oxytocin will start in about 3 to 5 minutes after IV administration, and the half-life of oxytocin is about 10 to 12 minutes, and the time to reach steady state is about 40 minutes. Yeah, certain facts we also know about oxytocin, and I'm sure we know this already, that the receptor sites will increase in number as gestation progresses and as labor progresses. However, we need to be mindful of the fact that when the sites get oversaturated, there's a decrease in myometrial function due to desensitization. And therefore, the longer you expose a woman to oxytocin and the sites get saturated, the myometrial function becomes ineffective in a sense. And so it's a research done that showed that my mitral samples taken after 12 hours of labor, 50%, 50 times less oxytocin receptor activity when compared to those less than 12 hours. So the more you expose to oxytocin, you get desensitization, decreased myometrial function, and then fewer receptors. And therefore, there are points where you need to give a break. When oxytocin binds oxytocin receptors, there's a decrease in sensitivity, and this desensitization will lead to less effective contractions, including coupling and tripling. Traditional teaching has been that you drive oxytocin through this to try and regularize the contractions, but research has shown that the opposite is true. Prolonged administration of high doses may elevate the resting tone, and therefore there's incomplete relaxation and therefore poor oxygenation for the baby. Experts will recommend discontinuation of oxytocin when there are signs of downregulation or desensitization and infusion of some fluids. And when oxytocin is resumed, normal activity, uterine activity may be achieved. And we need to understand that even if palpated contractions are mild, once there's cervical change, it's adequate. And once labor is established to about 5 centimeters, as you approach the second stage of labor, even decreasing or discontinuing oxytocin have not shown any appreciable change in the length of labor. 90% of women deliver successfully with just 6 units per minute of oxytocin. So we don't need to be driving everybody up to about 20 milli-international units per minute. Oxytocin can cause sustained contractions when we have a hypertonic contractions, and these can cause bradycardic episodes. So you can see that in this picture. And these will resolve once oxytocin is stopped. Again, hypertonic contractions with raised baseline will lead to bradycardia. And this can be improved by stopping the oxytocin and sometimes giving a tocolytic agent. Now, if a trace is pathological, then oxytocin should not be used, as it can cause further hypoxia to the baby, and we need to really understand this. The effect of oxytocin may take about 40 minutes to reduce by half. That's the half-life of oxytocin. Now, there's a debate on how to stop and start oxytocin. One practice point is to note how long it takes for the heart rate to normalize and allow an equal amount of time for biochemical normality, and resume oxytocin at half the previous dose rate. Another point, which is based on the physiology of oxytocin, is if the oxytocin is discontinued at less than 20 to 30 minutes, then the oxytocin can be restarted at a lower rate prior to when hyperstimulation and pathological CTG was seen. If the infusion has been held for more than 30 to 40 minutes, then can be restarted near the dose rate at which it was stopped. The various protocols, the low dose and high oxytocin dose protocols, documented in literature. And generally, the dosing protocols are recorded in milli-international units per minute, and it's encouraged that these units are used in the labor suite. Low dose protocols will start at 0.5 to 2. High dose protocols start around 6. And there are increments of 1 to 2 in the low dose and 3 to 6 in high dose protocols. To understand oxytocin infusion rates, it's normally quoted, like I said, in milli-international units per minute. So typically on a labor ward in a place like Accra or Kumasi, we use 5 units in 500 mils, which is essentially 5,500, which is 10 million international units per mil. And since 60 drops per minute comes to about 10 international units per minute, 15 drops per minute is 2.5 international units per minute. So you realize that this is a high dose protocol that we use. In most places in the Western world, they use 10 or 30 international units in 500 mils, which when you calculate will come to essentially 1 million international units per mil. And most of them use infusomates or infusion machines to titrate the drip. So when you compare the two, you realize that in most places where they can have the infusion pumps, it gives them a wide range of oxytocin doses. Because when you start with 30, 10,500, and you're doing 1 mil per hour, you could move from 1 to 2 to 4 to 8 to 12 to 16 to 20. So it gives you a wide range. However, if you're using a drip set and you're doing 15 drops per minute and increasing every 30 minutes, when you start at 15, you're doing 2.5 million international units per mil. Move to 30, you're doing 5. When you move to 60, you're doing 10. And then you're stuck. You can only go up if you want to increase your oxytocin rate to 10 units in 500 and go through that race, but you'll be going at very high doses. For safe administration of oxytocin, it is always good to have a pre-oxytocin safety checklist in your labor suite. You don't need to remember this, just print this and put it on your labor suite so that whenever anybody is going to start oxytocin, they go through this checklist. And this is how high reliability organizations operate. And these are organizations that have safety at the heart of the operation. So organizations like the military, aviation, nuclear plants, these organizations do not rely on memory of people, they rely on checklists, because when we rely on people's memory, then human factors set in. So what we'll remember at 2 a.m. is very different from what we'll remember early in the morning. However, if there is a checklist, it doesn't matter the knowledge of the person on the ground or how tired they are, they go through it and they do the right thing. So before you start oxytocin, because it's a high risk drug, you need to take consent from the patient and document that you've taken consent from the patient. And informed consent means you educate the patient about the risk of oxytocin and make sure they've understood it before you prescribe it. You need to confirm the gestational age to make sure you're not delivering a preterm baby iatrogenically. You need to ask yourself, is this baby too big? Why is this labor not progressing? You need to be sure it's a cephalic presentation. You're not putting oxytocin on a breech presentation, for instance, in a singleton. Is that uterine activity ongoing already? Because if she's having adequate uterine activity, what are you really using the oxytocin for? And is there progress vaginally? Is there no contraindication like a placenta previa or something like that going on? You need to make sure the baby is well. So you need to have a normal CTG to reassure you. And you need to have a good interval between oxytocin and prostaglandin agents. And you need to explain the common side effects to a patient before you start your oxytocin. So things like headache, nausea, vomiting. And you have to let them know they're going to have more painful contractions. The NICE guidelines say that you should offer a woman an epidural before you start oxytocin because it's more painful. Because oxytocin also has receptors on the heart and releases ANP, it can stimulate vagal receptors and cause bradyarrhythmias as well. So mothers need to know that it can cause their heart rate to drop a bit. Oxytocin can also cause uterine hyperstimulation. We know this, and this can lead to fetal distress, asphyxia, and fetal death. There's also a risk of neonatal jaundice, which you need to let the mother know. And as always, you also need to let them know because of the ADH effects of oxytocin, you can have water retention and water intoxication. And with water intoxication, you have hyponatremia. And sometimes you can have profound hyponatremia in labor when you're given a lot of oxytocin, which can cause seizures in both the mother and the baby if it's quite profound, like when you get into a region of less than 125 or less than 120. It can cause QT prolongation, myocardial ischemia, and pulmonary edema from fluid overload. We also know that you can have an embolism, amniotic fluid embolism from high doses. And because oxytocin also releases nitric oxide, rapid infusions can cause hypotension, which in effect can cause fetal distress from the hypotension and reduction of placental bed circulation. So you need to explain the risks, at least the common risks to the mother before you start the infusion, so that she understands and takes an informed decision. For safe use of oxytocin, would normally encourage a standard preparation so that people are not doing calculations on labor ward, which can lead to drag errors. And people need to have a deep understanding of what oxytocin and what it does. So understanding of the pharmacokinetics is very helpful. And there should be a physician who has the ability to intervene, like with cesarean section or instrumental delivery skills available when you are starting oxytocin because of the risk of fetal distress. We should encourage adequate hydration and the presence of nurses to monitor the mother carefully when we are starting oxytocin. And we should respond promptly to excessive uterine activity by stopping it or giving a tocolytic to try and improve things. And so there's a whole checklist of safe practices with oxytocin use that we need to adhere to. We know there are a lot of medical legal issues around oxytocin use, mostly are revolved around inadequate uterine contraction monitoring. Sometimes somebody will start oxytocin, walk off, and by the time you come back, half of the bag is gone. That's quite dangerous, can lead to hyperstimulation. Failure to recognize hyperstimulation or do anything about it, failure to use tocolytics, failure to recognize prolonged decelerations have all been key parts of litigation. Using oxytocin when there's a pathological CTG already, and all of that. Thank you.